Good evening, Dr. Mazen. Good evening, everyone.
Good evening,
Thank you.
everyone.
Good evening. I would like to thank this opportunity. I would like to thank Qasimi Ophthalmology International Conference for this opportunity to have a symposium about talking about dry eye disease. And I would like to thank Dr. Mazen to have the honor. We are so honored for you to be with us and to talk about dry eye disease today. Dr. Mazen is going to take us through a journey and a story about the dry eye disease. And Dr. Mazen is we're very happy and honored to have you with us. And please, you can start. I'm gonna leave the floor to you, and we're very honored that you're gonna be talking about the dry eye disease today.
Thank you very much, Yara. And I'd like to thank Dr. Al-Amri and Dr. Fatima Ibrahim for this opportunity. As usual, it is like a festival rather than a conference, and hopefully next time it will be physical. And it's my great honor and pleasure to be with you today. And I will start immediately the presentation. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. I'm going to share my screen. Now, today, I'd like to take you in a tour to show you three tales of a couple. To be scientific, let's say, we will go like systematically. So, of course, always when we want to approach a patient with dry eye disease, we have to take a history before examining the eye. The history should be very detailed history. So what I usually ask the patient is based, of course, on the TFOS DUSE 2 report. The duration of the symptoms, the severity of the symptoms, what types of treatments the patient took so far, any accompanying symptoms, any general diseases, the lifestyle, sorry for the typo, makeup, contact lenses, use of PC and screen hours. The environmental factors such as exposure to AC, pollution, heat, UV exposure, and salty water. Use of topical medications and use of systemic medications. Of course, the topical, I mean those medications not related to the dry eye for any other reason, for example, for glaucoma. Then we have to put in mind that there are main medications that they cause dry eye. The anticholinergic, diuretics, beta blockers, either systemically or topically, and antihistamines, anti-glaucoma medications. Then we go to the examination. The examination should be very detailed as well. So while taking the history from the patient, we have to keep an eye on the lids for the blinking rate. We have to, of course, examine and degrade the conjunctival injection or congestion, the tear film breakup time. It would be better if we can take it the non-invasive. However, if we don't have the non-invasive device, then we can do the stain. The tear meniscus, the height of the tear meniscus on the lower lid. Then we do staining to the cornea. We cannot imagine how much or how many cases we can find staining in the inferior, especially in the inferior part of the cornea, while when we examine with the slit lamp, we may not recognize that these punctate erosions are there. MGD, meibomian gland dysfunction, should be checked, and not only just by looking, we have to press on the meibomian gland to see the substance that may go out, whether it is like a toothpaste or it is just oily. We look at blepharitis, especially anterior blepharitis. Lacrimal passage, I always put my small finger on the lacrimal sac and press on it upward in order to see if there is any regurgitation, because many patients may suffer from dry eye symptoms while they have only like blockage in the lacrimal passage. I know it is paradoxical, but it is there. And sometimes we may increase the problem by putting punctal plugs. Corneal sensation should be checked in every patient. Eyelid closure, whether it is closed or not, and the type of closure. Sometimes you may discover floppy eyelid syndrome when you ask the patient to close the lids. Conjunctivitis, whether there is allergic or bacterial. Sinuses and nose. I always put my fingers here and check the sinuses of the patient, all sinuses, and I press especially on the frontal sinus, because sometimes any congestion in the sinus, especially in the frontal sinus, may cause as well the symptoms of the dry eye and irritation. Skin, especially that nowadays we are checking patients with masks. Just tell the patient, please remove the mask, because you may find rosacea or any clues of any atopic dermatitis, for example, which is predisposing factor, of course, to the dry eye disease. And it works looking at the joints of the patient. Just look at the joints, especially the fingers, elbow, if it's possible. Ask the patient about the joints as well. All right. Management. I always go through a staged management. Step 1, education, treatment of the underlying pathology. I discuss with the patient, how can we modify the environment that the patient is in, lifestyle modification as well, modification of topical and systemic medications, lubricants. Each lubricant has its own application. I don't believe that every lubricant is perfect for everybody, all right? So it depends on the situation of the eye, the inflammatory reaction, if it is there or not, as we will go through now the three tails. And lid hygiene and warm compresses. They are very important, of course, for the MGD. Now, if step 1 was not sufficient, then I add on it. So it's not an alternative, I add on it. We have to look for Demodex and treat it if it's there. MGD treatment, of course, by more sophisticated devices, thermal, laser, and so on. Mechanical expression, and so on. Topical anti-inflammatory medications, steroids, cyclosporine, and liftigrast. Topical antibiotics, like azithromycin. Now, if step 2 was not sufficient as well, then we add on it punctal plugs, but there must be no active inflammation. Otherwise, we are going to pool the toxins circulating over the ocular surface. They will stay there and they will make the problem much worse. We may think about autologous, allogenic serum eye drops, bandage contact lenses, sometimes oral anti-inflammatory medications such as tetracycline, erythromycin, and azithromycin. Now let's start with tail 1. A 27-year-old lady came with the complaint of chronic dryness, sensation, and itching. History taking shows that the duration was since 2 years, severity getting worse. What types of treatments? She tried many types of lubricants and steroids, topical steroids. Any accompanying symptoms? Yes. Pain and grittiness. Any general diseases? No. The lifestyle makeup? Yes. Contact lenses. Long usage of PC and screen hours, over 10 hours a day, including the mobile, of course. Environmental? Yes. Her office, her desk in the office is just opposite to the AC direction. She doesn't use any topical medications, and she uses antihistamine because she thinks that the grittiness and the itching can be treated by antihistamine. And we know that antihistamine is one of the major causes of dry eye disease, especially if it is taken for a long period of time. Examination, the rate of blinking was just 1 per 10 seconds. Okay. Conjunctival, let's say it is almost 6 times per minute. Conjunctival injection, which means too much blinking, of course. Conjunctival injection, none. BUT, 3 seconds. The tear meniscus is less than 0.5 millimeters. Staining, none. No staining in the cornea. Mild MGD, blepharitis, no blepharitis. The lacrimal passage, no stenosis and no regurgitation. The corneal sensation is present. Eyelid closure was normal. Conjunctivitis, none. Sinuses and nose, none. Skin, none. Joints, none. Great. So this is a summary of the findings. She is 27, so still young. She's a lady. Chronic dryness, itching, pain, and grittiness. She uses makeup too much. She uses contact lenses. She uses the long hours, the PC, the AC in front of her. She uses the antihistamine. The rate of blinking, as you see, BUT 3 seconds and TM is low. So it seems like evaporative. Anyhow, step 1. We go through the education, we go all these steps. I'm not going to repeat. Okay, but we have to emphasize on these items because they are related to her case. Great. So these are the recommendations based on the step 1. Stop the oral antihistamine. Stop the makeup. Can use the contact lenses, but with lubricant. She has not been using the lubricant with the contact lenses. Reduce the mobile time and control the PC time. Avoid direct AC flow. I told her to change the position of her desk and use a combination of lubricants. Okay, now she came after 2 weeks. I told her to come after 2 weeks. Still, she has some dryness sensation and grittiness. The BUT just increased a little bit, but still there are some symptoms. Here, I jump to step 2. Of course, step 2 doesn't mean that it's mandatory to find the eye like this one in the picture, that it is inflammatory. Sometimes the eye is white, but we need to go to step 2, like in this case. Okay, so in this case, I asked her to use the cyclosporine. And these are the recommendations. Keep no makeup. Stop using the contact lenses this time. I want to exclude more factors. Keep reducing the mobile time and the PC time. Use a combination of lubricants. Start using Restasis course for 3 months and come after 4 weeks for reassurance. Why for reassurance? Because people using the Restasis may suffer in the first period of time of some stinging, so may stop the medication. So I asked them to come for reassurance. Okay, so at 45 days now, she came, very rare dryness sensation, less dependence on lubricants, and the BUT was 9 seconds. So the recommendation, can go back to makeup, can go back to contact lenses, but with lubricants. Keep a combination of lubricants. I mean by the combination, we can use any composition, but another one should be with the oily substance that makes a layer to reduce the evaporation. Continue Restasis for the full course. Maintain the precautions of the screens and mobile, and follow up after 45 days again. So that was the case number 1. Now case number 2, 42-year-old male, suffering from chronic dryness sensation, itching, and redness. He was using nafazoline, which is the worst drops in the world. And I wonder why it is still being sold in the pharmacies. Plugs inserted 3 weeks ago, and the patient started irritation and discharge since 2 weeks. So after insertion of plugs. Okay, great. History. Duration was 5 years. Discharge and irritation, only 2 weeks. Severity, it was severe. He tried different types of steroids, antibiotics, and lubricants. He was suffering as well from fluctuation of vision. So it's not only to listen to the patient, what symptoms they suffer from. We have to ask more. Do you feel fluctuation of vision? Do you feel this? Do you feel that? Because it wasn't in the history. So fluctuation of vision. Any general diseases? No. The lifestyle? No makeup, of course. Doesn't use contact lenses. PC and screen hours was average because his job wasn't depending too much on the PC. But he is exposed too much to the UV because he is an outdoor profession. Use of topical medications, yes, Nafcon, and 2 types of hyaluronic acid. Do not be surprised because I see many patients coming with 2, 3 different types of different brand names of drops, but with the same composition. Use of systemic medications, no. Okay, examination, very frequent. Conjunctival injection, severe. BUT, 1 second. TM, tear meniscus, very small. Diffuse punctate in both corneas. MGD severe with telangiectasia on the eyelid. Blepharitis, none. Lacrimal passage, no stenosis, no regurgitation. Corneal sensation was present, eyelid closure normal. There was bacterial conjunctivitis, no sinus signs, skin, nothing, joints, nothing. So this is the summary. 42, 5 years of dryness sensation, itching, redness, and fluctuation of vision, not responding to steroids, antibiotics, and lubricants, was using Nafcon and 2 types of hyaluronic acid brand names. Plugs inserted 3 weeks ago. Irritation and discharge started after insertion of the plugs. He is exposed to UV, severe conjunctival injection. The examination shows severe conjunctival injection, grade 3, BUT 1 second, bacterial conjunctivitis, diffuse punctate erosions, and severe MGD with a telangiectasia. Great. So what are the recommendations? Stop hyaluronic acid. Why? Because hyaluronic acid must not be used when the ocular surface is inflamed, because it increases inflammation, because it is an acid. So look for other products without hyaluronic acid, at least for the first period until the inflammation calms down. Of course, stop Nafcon, the nafazoline. And don't trust any patient. Even if the patient swears, no, they still going on with it. So every time, ask them very honestly, have you used nafazoline or Nafcon? They will say, okay, once a time, yesterday there was an occasion like this. You have to tell them that as long as they are using this very bad drops, they will not find a solution wherever they go. Use other types of lubricant. As I said, remove the plugs. Remove the plugs, all right? Because we need a drainage for the toxins. Topical antibiotics and mild steroids for 2 weeks. Use sunglasses. Start Restasis course of 3 months. So from step 1, I start Restasis. I don't wait until step 2, because already there is an inflammation, severe inflammation. Start oral doxycycline course for 3 weeks and follow up after 2 weeks. And sometimes I tell the patient to come after 1 week. Great. After 2 weeks, still some redness, but no discharge and no irritation. Less hyperemia than last visit. Less severe MGD, BUT, small increase, minor staining, but much less than last visit. So there are results, but still ongoing. So the second step recommendation, stop topical antibiotics, because it was a good course of 2 weeks, and that's it. Keep the mild steroid on demand, okay? Continue the course of doxycycline and Restasis. Keep avoiding the hyaluronic acid. Keep avoiding the nafazoline. keep avoiding the UV, and come after 2 weeks. So the patient came at 1 month. Now the redness is on and off. Okay, mild feeling of redness, of dryness, a trace of hyperemia, mild MGD. The BUT is increasing, and there is no staining. So the recommendation: convert into long-lasting hyaluronic acid. Now you can use hyaluronic acid, and you can use long-lasting one or the rapid one. It's up to you. Depends on the viscosity. Stop the PRN topical steroids per needed, I mean. So no need for topical steroids because Restasis is handling the problem now. Keep avoiding the UV, continue the Restasis course, and follow up at the end of Restasis course. So that was the end of tail 1, tail 2. Now tail 3. 57-year-old male suffering from chronic dryness sensation and burning sensation and redness, on and off watery eyes, using anti-glaucoma drops since 5 years. History: so 5 years, moderate severity. He tried different types of lubricants. He suffers from fluctuation of vision, only AC exposure. He uses topical anti-glaucoma. All right, so the examination, let's say moderate conjunctival injection, 3 seconds of BUT, TM still is low, 0.5, a few punctate erosions, not punctuate, a few punctate erosions, moderate MGD, no blepharitis. We come here, we check the lacrimal passage. I found stenosis in the puncti, but there was no regurgitation. And this is very natural because of usage of the anti-glaucoma. They cause stenosis in the puncti and the canaliculi. Corneal sensation was present, eyelid closure was normal, no conjunctivitis, and none of the other points. So the summary was like this: 57-year-old male using anti-glaucoma drops since 5 years, exposure to AC, moderate chronic dryness sensation, burning sensation and redness, on and off watery eyes, fluctuation of vision, tried different types of lubricants and antihistamine drops, moderate conjunctival injection, BUT 3 seconds, stenosis in the puncti, a few punctate erosions, and moderate MGD. So what to do? Switch to preservative-free anti-glaucoma medications. This is the most important. So I sent him to his glaucoma specialist, asking him, please, either reduce the number of medications you are giving to the patient, do a combination as much as possible, use preservative-free medications. So you have to act, you have to find a solution for me. I will not accept that you'll say, this is the maximum, this is the, because nowadays we have plenty of options in the market. Stop hyaluronic acid, as I said, because the eye is inflamed for at least 1 month. Start a 3-month course of Restasis, fluorometolone for 1 week, avoid AC, and come after 2 weeks. Now the patient came after 2 weeks. Better dry eye sensation and redness, but still there. The watery is still on and off. The BUT is better. No staining, mild conjunctiva injection. In this stage, I can now dilate and inspect probing irrigation of the nasolacrimal duct because there is stenosis. For sure, there is a problem in the canaliculi causing excess water, tears, and the excess tears and low drainage will cause more toxins on the ocular surface and causing this problem. So dilation of the puncti, and there was positive irrigation, but under pressure. And I told the patient, please come after 1 month. The patient came at 45 days. So 1 month after the last visit, I mean. A rare sensation of dryness, no redness, BUT almost normal, and no watery eyes. So the take-home message. Message number 1, be a good listener. Message number 2, be a good listener. Message number 3, be a good listener. Message number 4, be a thorough examiner. And message number 5, be systematic rather than dramatic. And thank you very much.
Thank you so much, Dr. Mazen, for those very interesting cases from your rich practice in the clinic. Thank you so much. Now we can take any questions if we have any questions. And I also received a question that I would like to ask you as well.
Thank you very much.
Can we, I think we, can we start with the question that I have received first?
Please.
Okay. You mentioned, doctor, in one of the cases that in one case you directly go for step 2 with an anti-inflammatory treatment. If you can summarize to us in which specific cases you directly go to step 2 and you do not wait.
Yeah, very good question. Actually, when the eye is inflamed, any ocular surface disease, be it, for example, blepharitis, MGD, conjunctivitis, chronic injection of the cornea of the conjunctiva. If I find as well severe punctate erosions, too much punctate erosions, even if the eye is quiet, in this case, yeah, I jump to step 2 beside step 1, of course. So, and when let's say, when the patient is exhausted of full range of medications and still suffering from too much symptoms, in this case, I'm not going to wait just to change the lubricant or to give some steroids, especially if the patient has taken a lot of those things. So immediately I go to the anti-inflammatory.
Very clear. Thank you so much, Dr. Mazen.
Pleasure.
I guess if we don't have any questions, we'd like to thank the audience and wish them a very good evening. And thank you again for a quick scientific committee for this opportunity to talk about dry eye disease. And thank you so much, Dr. Mazen, for sharing your experience. We're very honored and pleasured to have you with us.
Thank you very much. Likewise.
Thank
you for inviting me. It's a great honor to be to speak about this product. And thanks to COIC as well for their the opportunity.
Thank you, Dr. Mazen. Thank you, everyone. Have a good evening.
For you too. Goodbye. Assalamu alaikum wa rahmatullahi wa barakatuh.
Bye-bye.